Hi, I am Dr. Raul Chavez-Valdez, an associate professor in the Department of Pediatrics, Division of Neonatology, and a co-director of the Neuroscience Intensive Care Nursery Program, NICN. Today, I would like to talk to you about a commentary that I had recently made with my colleagues from Pediatric Neurology and Neonatology at Johns Hopkins University and the Kennedy Krieger Institute, along with the Pediatric Neurology team from University of California, San Francisco. This commentary was made in a letter to the editor of the Journal of Child Neurology in relation to one of several papers proposing treatment with antipsychotics, such as risperidone in chronic neonates suffering agitation and restlessness in the NICU, which phenotypically may resemble delirium in older children and adults. The paper was published in April 2024. Our concerns were focused in the scientific premise, neurobiological assumptions, robustness of the methods, and validity of the conclusions. In summary, as a group, we argue several points. First, as delirium is an acute neuropsychiatric disorder with significant disturbances in attention, awareness, and cognition without a previously diagnosed cognitive impairment, we argue that the identification of an acute cerebral disorder and the exclusion of a cognitive impairment is, in the best case scenario, challenging in a neonate with a rapidly developing brain subject to the impact of comorbidities and our own interventions. Further, even if a premature infant has no comorbidities, they develop difficulty with the state regulation or motor manifestations mimicking delirium. As a relatable example, as the neonate developmental needs for social interaction increase, and they remain mostly bound to their cribs due to their illnesses, they may develop restlessness and agitation, which are further complicated by sedation strategies reversing their sleep-wake cycle. Thus, restlessness and agitation in this population is not delirium. Second, as delirium has been hypothesized as a disconnection syndrome caused by loss of functional networks, defining delirium requires functional neural pathways, synapses, and biochemical and neurotransmitter networks involving many brain regions and neurotransmitter systems. These networks and neurotransmitter systems are still literally in their infancy and may not reach maturity for up to a decade. Thus, the structural and biochemical substrates are likely not sufficiently developed during infancy to make a diagnosis of delirium in neonates, even less in preterm infants. Lastly, antipsychotic medications such as risperidone modulate the function of many neurotransmitters, those that are essential for brain development, and thus manipulation of their activity and their receptors at this early stage of brain development could have unforeseen consequences and thus requires careful scrutiny and long-term follow-up. To this day, preclinical and clinical data on these consequences and side effects are lacking. I hope that I have been able to explain why, as a group, we do not support the use of antipsychotic medications in neonate and any post-term corrected age. We strongly believe that these medications and any efforts made to study them must follow the utmost level of rigor to prevent unintended consequences in this very high-risk population. We're extremely grateful to the families of our patients who trust us to make the best decision for their baby during their stay in our NICUs and beyond. We strongly believe that this is our duty to advocate for safety in any decisions and therapeutic shift to prevent harm. Once again, thank you for trusting our team. We are honored to take care of your family.